Hello, welcome to the Kampala Advanced Trauma Care course series of lessons. Today we are going to talk about shock, and we shall talk about shock in two parts. This is part 1. I'm Dr. Namugamatha Monica. I'm a general surgeon working with Mulago Accidents and Emergency Department. Our outline today, we are going to define shock, talk about physiology of shock, body's response to shock, signs and symptoms of it, laboratory tests, stages of shock, types of shock, and we shall summarize. So shock is widespread inadequate tissue perfusion leading to an imbalance in oxygenation, which if prolonged will result in irreversible organ damage and ultimately death. So when you have a state of shock, there is more demand for oxygen than what the body can do. So when you have reduction in blood pressure, there will be a reduction in the stretching of baroreceptors. Baroreceptors have stretch receptors. And when this happens, there will be a reduction in the firing of these baroreceptors. So signals will be sent to the cardioregulatory center, which is found in the medulla, via the glossopharyngeal and the vagus nerve. So the cardioregulatory center will inhibit the parasympathetic nervous system and activate the sympathetic nervous system. The sympathetic nervous system activation will lead to an increase in heart rate, an increase in stroke volume, which will result in an increase in cardiac output and mean arterial pressure. So the sympathetic nervous system also activates the vasomotor center, which is found in the medulla as well. So signals will be sent through the sympathetic nerves in the spinal cord to the adrenal medulla, which will secrete adrenaline and noradrenaline into the bloodstream. These two hormones will cause vasoconstriction, and this vasoconstriction will lead to an increase in systemic vascular resistance, which will lead to an increase in the mean arterial pressure. So in the adrenal gland will respond to low blood pressure by producing renin. Renin is an enzyme and it acts on angiotensinogen, which is produced in the liver, converting it into angiotensin 1. And angiotensin 1 in the lungs, under the influence of angiotensin converting enzyme, will be converted into angiotensin 2. Angiotensin 2 works to increase thirst, so the individual will take in more water, and then it will cause vasoconstriction, which will lead to an increase in systemic vascular resistance, which will ultimately lead to an increase in cardiac output. Then it will also trigger the release of aldosterone in the kidneys. Aldosterone will cause an increase in sodium reabsorption. Sodium is usually reabsorbed together with water. So this will lead to an increase in circulating volume, which will lead to an increase in the mean arterial pressure, preload, and cardiac output. In the posterior pituitary gland will recognize an increase in the osmolarity of the blood flowing through it, and then because of this, it will respond by producing antidiuretic hormone. Antidiuretic hormone will increase the absorption of sodium and water. So signs of shock. How do we know that one is in shock? First of all, they'll have a low blood pressure. They'll have an increase in the heart rate, which is not always the case. They'll have a weak, thready pulse. The respiratory rate would be increased, however, the breaths will be shallow. The patient will have pallor. They will be confused, lethargic. They might have absent or reduced bowel sounds. Their extremities will be cold and clammy, and they might have mottled skin. So laboratory tests, we shall have increased serum lactate because lactic acidosis during shock, the body will change from aerobic to anaerobic respiration, and a product of that anaerobic respiration is lactic acid. So checking for levels of serum lactate. Serum lactate will be a measure of severity of shock. And because of this lactic acid, we shall have So what are the different stages of shock? We have stage 1 to stage 3 in order of severity. So stage 1 is also called the initial stage or compensated stage or non-progressive stage. Here, the body is switching from aerobic to anaerobic respiration. There is no drop in blood pressure. The heart rate increases in order to maintain the cardiac output. There will be, there will be peripheral vasoconstriction. The patient will be pale. Because of the peripheral vasoconstriction, the patient will have cold, clammy skin. And in the endocrine system, we shall see a release of renin, an antidiuretic hormone. This is the ideal time to identify and treat shock. However, if not treated, it will progress into stage 2. Stage 2 is also called the decompensated or progressive stage. Compensatory mechanisms begin to fail. The blood pressure falls. Hypoxic injury, secondary to reduced perfusion and oxygenation if persistent, starts to affect different organs and their effects start to show. So there will be reduced cerebral perfusion pressure leading to confusion, lethargy, and altered mental state. In the heart, we shall see acute myocardial infarction because of ischemia to heart muscle. Then we shall see these arrhythmias. In the kidney, there will be acute tubular necrosis, which will eventually lead to renal failure. In the gastrointestinal tract, there will be reduced peristalsis, ileus, and even ulcers. In the liver, we shall have shock liver, or we could call it acute hepatic failure. So we shall have an elevation of liver enzymes. In the lungs, there will be increased capillary permeability into the alveoli, leading to fluid filling up the alveoli, which will lead to acute respiratory distress syndrome and subsequently respiratory failure. In the blood vessels, there will be damage, ischemic damage inside blood vessels. This will lead to formation of multiple clots globally. So the body uses up clotting factors trying to clear these clots, which will lead to DIC. If the patient is treated at this stage, there is a big chance of them making a full recovery. If, however, the patient is not treated, shock will progress into the third stage of shock, which is also called refractory shock or irreversible shock. In this stage, irreversible changes happen. There will be multiple organ distress syndrome secondary to prolonged hypoperfusion. So the biggest challenge with this stage is there will be no telltale signs that the patient has crossed into this stage, because the patients can still respond to resuscitation. For example, their blood pressure can still increase from giving IV fluids. This is a very bad stage because the patient inevitably dies. So we should work very hard during resuscitation to prevent this stage. So types of shock. So we have different types of shock, and we are going to look at them, but then we shall get back to hypovolemic shock in more detail. So the first type is hypovolemic shock. First of all, the word hypo, we could break it down. It could give us a very big clue on what this kind of shock is. So hypo means low, vol means volume, emic means blood. So in this kind of shock, we have a lack of blood volume. So there are different categories under hypovolemic shock. We have external bleeding. There could be internal bleeding, which could be from GI bleeding or ruptured ectopic bleeding vessels, for example, from a ruptured aneurysm. Or there could be fluid loss. It's non-hemorrhagic. There could be fluid loss like from burns, excessive vomiting, severe diarrhea, severe dehydration, and ascites secondary to hypoalbuminemia. Then the last category could be excessive use of diuretics. as the cause of the hypovolemic shock. So pathophysiology of hypovolemic shock. So low blood volume leads to a reduction in the filling pressure of the heart, which is also called the preload. So reduction in preload will lead to a reduction in stroke volume, which will lead to a reduction in cardiac output. So compensation, there will be increased vascular tone, especially in the venous system, leading to an increase in the venous return. And then there will also be an increase in the heart rate. So signs of this shock, we shall have a low blood pressure and an increase in the heart rate, which is compensatory. We shall have cold, clammy extremities, which is because of peripheral vasoconstriction. Yes. And then the laboratory tests you can carry out serum lactate in order to see the severity of shock. We can do a CBC in order to see the blood levels. And then we can do ABGs in order to show oxygenation around the body. We need to, the ABGs assess for oxygenation, yes. We shall go back to hypovolemic shock in our second lesson on shock in detail. Next, we have cardiogenic shock. Cardio means heart, genic means originating. So basically, this is shock originating from a heart issue. So there are four main causes of hypovolemic shock, cardiogenic shock. There could be an issue with the filling of the heart. There could be a contraction issue. For example, if you have heart failure or cardiomyopathy or myocardial infarction. There could be a conduction issue. This is what happens when you have arrhythmias. Or there could be structural defects like valvular disease. So in what causes cardiogenic shock? So in cardiogenic shock, the heart is not pumping as well as it should. There is no problem with the volume. So because the heart is not pumping as well as it should, there will be backing up of blood within the left atrium, then eventually into the pulmonary artery and the lungs, then back into the right ventricle. And if progressive, it will lead to also backing up of fluid to the rest of the body. So pathophysiology. So we have diastolic failure. So over time, ventricles become enlarged and stiff, and so less compliant. And when they are enlarged and stiff, there will also be reduction in space within the ventricles. So this will reduce the preload, which will lead to a reduction in cardiac output. So what about cardiomyopathy? What happens during cardiomyopathy? So let's take myocardial infarction, for example. Myocardial infarction will lead to muscle death, and the dead muscles or the affected muscles will not contract as well. Then there will be thickening and enlargement of walls, which will lead to reduced contractility. So again, this will cause the heart not to work as well as it should. So when one has arrhythmias, we see dyssynchrony between the atria and ventricles, which impacts contractility. Remember, in order for our heart to contract, we have our sinoatrial node, which is the pacemaker, initiating the impulse, which will spread to the atrioventricular node, eventually into the band of His, and then will cause the heart to contract. So if there are arrhythmias, there will be dyssynchrony between these mechanisms, so there will be dyssynchrony between the atria and the ventricles, and this will impact contractility. Contractility will be disorganized. So regurgitation from incompetent valves leads to backflow, which leads to reduced cardiac output. So what are the signs of cardiogenic shock? Depending on the cause of it, the patients will present with chest pain, which is from angina. They will have a low blood pressure. They'll have an increased heart rate, again, which is a compensatory mechanism. And because of the peripheral vasoconstriction, we shall have cold, clammy skin. Then when you do a chest x-ray, you shall notice that the heart shadow will be bigger, so there will be cardiomegaly. There will be pulmonary edema, so the patient will present with cough, bloody sputum, and jugular venous distension. Then there will be peripheral edema because of backing up. What labs can we do to diagnose cardiogenic shock? So again, we have our serum lactate, which will be elevated. Our air blood gases, we do them to assess oxygenation. Troponins will show heart damage. They will be elevated. A chest x-ray will show pulmonary congestion. An EKG will show arrhythmias, or we could see signs of MI. And an echocardiograph is the gold standard because it can show the cause of the cardiogenic shock. So we can also do a Swan-Ganz catheter placement. This one can be used to show the cardiac output, the contractility of the heart, and the capillary wedge pressure. So how do we treat cardiogenic shock? First of all, we have to improve oxygenation, so we have to give the patient some oxygen. Then we have to do certain things which all work towards supporting the cardiovascular system. So we increase systemic vascular resistance by giving vasopressors, that's epinephrine and norepinephrine. Then we increase contractions of the heart by giving ionotropes like dobutamine. Epinephrine will also work to increase contractility of the heart. So then if arrhythmias are the cause, we need to fix arrhythmias by giving anti-arrhythmic drugs, for example amiodarone, lidocaine, or performing cardioversion. Then we could also consider pacing by placing a pacemaker. And then we could consider temporary assist devices like intra-aortic balloon pump, impellers, ECMO. And then fixing the underlying cause, for example, MI, we do open heart surgery or CABG, or assist devices like the artificial pump. All these are just used in the interim, but ultimately the patient might require a heart transplant. So obstructive shock is another type of shock. This results from mechanical obstruction that impacts blood flow. So let's look at some of the causes. So tension pneumothorax is one of the causes. Tension pneumothorax causes increased intrathoracic pressure in the affected side, leading to narrowing of the vena cava and reducing of the preload. The pressure within the chest or at the affected side also constricts the heart, inhibiting its filling and contractility. We shall have a deviated trachea away from the affected side. Then we shall have hyperextension of the hyperextension of the affected side of the chest, and that chest will be hyperresonant if you try to percuss. There will be reduced movements. There will be absent breath sounds. The patient will be tachypnic and hypoxic. So diagnosis for tension pneumothorax, it should really be a clinical diagnosis because it needs very fast intervention, or else the patient could decline. The patient's condition could decline very fast. However, it has also been diagnosed using chest x-ray. The treatment of tension pneumothorax is needle decompression in the second intercostal space in the mid-clavicular line to release the tension, after which we put a chest tube. So this tension pneumothorax has to be treated fast because it's life-threatening. It causes pulseless electrical activity and eventually death. So cardiac tamponade is another example of obstructive shock or another cause. So in cardiac tamponade, there is a buildup of fluid within the pericardial space. So the heart loses its ability to expand. This fill-up of fluid within the pericardial space also reduces the chamber size, leading to a reduction in preload and venous return, which will eventually lead to a drop in our cardiac output. So signs and symptoms, in addition to other signs of shock, the patients will have what we call the Beck's triad. They'll have muffled heart sounds, jugular venous distension, hypotension, especially with narrowing of the pulse pressure. Pulse pressure, we get it by subtracting the diastolic from the systolic blood pressure. So diagnosis is done by doing a cardiac ultrasound scan or an echocardiogram. Treatment, there is need to drain this fluid, so they'll ideally do a pericardial drain or pericardiocentesis. So constrictive pericarditis is another cause of obstructive shock. In constrictive pericarditis, we have thickening and rigidity of the pericardial sac, and it's usually secondary to infection. So the treatment of it will be giving anti-inflammatories, steroid, and pericardiectomy. We remove the pericardial sac. So another cause will be aortic stenosis. In aortic stenosis, we have calcium deposits on the cusps of the heart valves or the aortic valve. This leads to narrowing of the valve and hence reduction in blood flow to the aorta. So we diagnose it by doing an echo, and the treatment is valvuloplasty or valve replacement. A pulmonary embolus is another cause of obstructive shock. So usually it begins with deep venous thrombosis, and when you have DVT, a clot may dislodge, and the clot will flow freely within the bloodstream to the right side of the heart and then into the pulmonary veins to the lungs. So signs of pulmonary embolus, we shall have increased respiratory rate, cyanosis, and pallor. Sometimes if you have a big clot, a saddle clot, it might cause sudden death when it blocks off complete blood flow to the lungs. So diagnosis, we do a ventilation perfusion scan and a CT angiograph. Treatment is in two ways. Either we dissolve the clot with heparin and TPA, or we can remove the clot by doing an embolectomy. So another type of shock is distributive shock. Distributive shock can be caused by several other things. For example, anaphylaxis, septic shock, yes, to mention but a few. So during anaphylactic shock, ana means against, and phylaxis means protection. So this shock is as a result of the body's own immune system. So the body responds to an allergen, so you need to have an allergen. So when the body is exposed to the allergen, the body responds to the allergen by causing a massive release of histamine. So there are two types of anaphylactic shock. There is the immunologic shock or anaphylaxis, or the non-immunologic shock, also called the anaphylaxis. So in immunologic shock, or in the immunologic type of anaphylaxis, you have an allergen in the bloodstream. The body is exposed to the allergen. So that allergen, when it gets to the bloodstream, it interacts with B cells, and the B cells, because of this, produce antibodies, which are IgE. These IgE attach to mast cells. Mast cells are immune system mediators. So the body is sensitized to this antigen. So when another exposure at another occasion of the similar antigen happens, the allergen of the same allergen happens, the allergen binds to mast cells, leading to cytokine release, which recruit more white blood cells. So white blood cells and mast cells massively release histamine. This histamine binds to receptor sites. There is the histamine 1 receptors and the histamine 2 receptors. Histamine 1 receptors lead to an increase in capillary dilatation, which leads to a lot of fluid extravasation into the extravascular space, which leads to a massive reduction in volume, intravascular volume, which will lead to a low BP. The vascular dilatation will also, or capillary dilatation, will also lead to a reduction in the systemic vascular resistance, which will worsen the blood pressure or affect the cardiac output. So increased capillary permeability, like mentioned earlier, will lead to leaking of fluid into the extravascular space. This will lead to edema, so the patient will swell up, and of course contraction of the intravascular space. So increased bronchial smooth muscle contraction to the lungs, it will increase bronchial smooth muscle contraction. This will lead to bronchoconstriction and edema, which will lead to compromised airways, which will lead to acute respiratory distress syndrome and eventually respiratory failure. To the heart, it causes a reduction in the AV conduction. So the H2 receptors are usually found in the stomach, and it will cause this will cause an increase in the gastric acid production, which will cause nausea and vomiting, which will lead to an increase in the risk of aspiration. So vascular smooth muscle relaxation leads to a reduction in systemic vascular resistance, which will lead to reduction in pressure. That is how the immunologic works. The non-immunologic anaphylaxis, on the other hand, doesn't require initial sensitization. The allergen interacts directly with the receptors on mast cells, and then the rest of the cascade is the same. So signs of this shock, we have low blood pressure, edema because of extravasation, increased heart rate, which is a compensatory mechanism, bronchoconstriction, itchiness, flushing of the skin, and rhinorrhea. Treatment, we usually, remember, we always look at our airway ABCs, airway, breathing, circulation. So intubation and ventilation. The patients might require intubation and ventilation. Then epinephrine to increase sympathetic response. Then we give intravenous fluids to expand the intravascular volume. Then we give antihistamines. Then corticosteroids to prevent rebound anaphylaxis. Then albuterol to dilate the constricted bronchioles. Then neurogenic shock is another example of distributive shock. So neuro means to do with the CNS. Genic, originating from. So the cause is usually an injury to the cervical and upper thoracic. So usually T6 and above. When this happens, when injury to T6 and above happens, there will be an impact on the sympathetic nervous outflow. So there will be no response, no sympathetic response, but there will be a preserved parasympathetic activity or response. So remember what we've talked about earlier. What the sympathetic nervous system does is a fight or flight response. So lack of this sympathetic nervous activity will lead to a reduction in the systemic vascular resistance and cause a low blood pressure. You shall have vasodilatation, reduced cardiac contractility, and there will be absent sympathetic nervous input to the synatrial node, leading to a reduction in the heart rate or bradycardia, and there will be a severe decline in blood pressure. So the hallmark of this neurogenic shock will be a low blood pressure with an associated low heart rate. So signs of neurogenic shock, we shall have a low blood pressure and a bradycardia because there is no sympathetic nervous stimulation to the synatrial node. So there will be body core hypothermia. The extremities, because of the widespread vasodilatation, will be warm and dry. So treatment, first of all, we need to protect the spinal cord to avoid worsening the damage already caused. So remember to log roll the patient, place a cervical collar, a rigid neck cervical collar to prevent further damage. So we shall give intravenous fluids to replace the intravascular volume. Then we shall give vasopressors to constrict vessels in order to increase the systemic vascular resistance. Then we shall give ionotropes to increase cardiac contractility. Then we shall increase the heart rate by giving dopamine or by inhibiting the parasympathetic nervous system with atropine. Then sometimes the heart needs pacing, and we need to protect the airway because the patient is unable to do that on their own. So septic shock is another example of distributive shock. So septic in the past or even up to present means rotten. So it is secondary to systemic infection, and mortality in septic shock is still high. It's about 50%. So pathophysiology, we have systemic infection leading to massive release of cytokines and nitric oxide from white blood cells. This nitric oxide causes vasodilatation, which will lead to a reduction in systemic vascular resistance, which will lead to reduced preload and subsequently cardiac output. It will also increase the leakiness of vessels. So we shall have, or the permeability of vessels, so we shall have fluid leaking into the extravascular space, which will worsen the already low BP. So relative hypovolemia, which will lead to reduced oxygenation of tissues globally. Then white blood cells also release lytic enzymes, which are supposed to destroy pathogens. These lytic enzymes, however, also destroy the endothelial cells, leading to an increase in permeability of these cells. So the damaged cells will release platelet aggregation factor, which aggregates platelets, leading to blockage of small vessels. Cytokines and inflammatory mediators lead to vascular damage in the lungs, which in the heart, initially there is a compensatory increase in heart rate. Eventually the heart rate reduces. Contractility reduces, which causes a fall in cardiac output. So signs, we have early and late signs. Early we have fever, dry dry skin, increased respiratory rate, anxiety and restlessness. Late we have cold, clammy skin, acute respiratory distress syndrome, respiratory failure, obtundation, coma, reduced urinary output, reduced bowel sounds, glucose regulation disturbances secondary to the hypermetabolic. So investigations that can be done include blood culture, serum lactate level, ABGs to look at oxygenation, CBC to look at the blood level. C-reactive protein can point to severity of infection. CBC, we can also look at the WBC levels and the platelets, and then cortisol levels. Treatment, in the first hour we need to check the lactate and also do blood cultures. So we should give broad spectrum antibiotics and adjust according to the sensitivity pattern that comes out of sensitivity tests after the blood cultures. Then intravenous fluids if hypotensive, then serum lactate more than 4, and the dose should be 30 ml per kilogram. If hypotension persists, then we need to give vasopressors, and the aim is a mean arterial pressure of more than 65. Then oxygenation of the patient, then support failing organs, for example the kidneys, you do dialysis, the heart, we give ionotropes, then steroids to reduce the widespread inflammation. In summary, shock is inadequate tissue perfusion and oxygenation. There is need to recognize its presence and etiology first so that we can be able to treat it accordingly, and then remember to replace like with like. Ensure adequate resuscitation to to prevent irreversible shock. Thank you.